Tonight's program is Key Advances in the Management of Colorectal Cancer, the Role of Molecular Residual Disease Assessment. Speaker is Dr. Tanio Saab, the Program Leader, GI Oncology at Mayo Clinic in Scottsdale, well known to most of you. I want to thank everybody in advance for submitting some good cases for discussion. And with that, Tony, I'll let you go ahead and begin.
All right. Well, thank you. Great to see good friends and colleagues on the call. So I will be discussing key advances in the management of colorectal cancer. I'll focus on minimal residual disease assessment, as this is emerging as one of the challenging areas in our practice, and certainly a lot to continue to learn in terms of how to integrate, these MRD platforms into the clinic. The whole field of circulating tumor DNA has really taken on a good life of its own in our practice. So there are different applications for circulating tumor DNA as liquid biopsies for precision medicine, including early detection of cancer. I'm not talking about this, but GRAIL is one example of such, not set for wide usage, but finding its way there. Also determining the risk of metastatic prelapse, and this is where we'll focus most of our discussion. And then also, utility in the more advanced settings to identify therapeutic targets. So within, 6 to 7 days instead of waiting for tissue, and then detection of resistance mechanisms. And that's mostly experimental at this point of time. When we think about MRD, what does that mean? Minimal residual disease. So think about your patient with early stage colon cancer, or cancer overall, but colon cancer for the sake of this discussion, who presents with early stage, is deemed as a surgical candidate. The patient gets resection, and ultimately, the clones, the remaining clones go at a minimum, but they're not cleared. Adjuvant chemotherapy clears, one of the clones, but one of the clones remains there. Now you do your scans, you do your CAs, etc. Everything looks relatively good. And if you do your MRD assessment, there's a good chance you're going to pick up a positive here, and MRD positive disease without evidence or clinical evidence of recurrence. And there's this lead time between, when MRD is positive and when the patients recur. And, the most pressing question for our practice is, what do you do with a patient who has MRD positive disease and yet nothing on the scan or anything evident per se? Today, we don't have that answer. And this is what a lot of these randomized clinical trials are doing. But let's think about it. Why is it so important? I mean, think about stage 2 colon cancer patients, and specifically the lower risk patients. The initial studies that looked at adjuvant chemotherapy, which ultimately yielded that there is no meaningful benefit for patients in the setting. You have to treat 100 patients to benefit 4. And so you essentially expose 100 patients to the toxicity of the chemo, where 80% will be cured by surgery, will never need any chemotherapy in their lifetime, and then 4 out of the 100 will, and unfortunately another 16% will be chemo resistant anyways. So how do we get to the point where we're able to pick those 4 patients and be able to identify those at risk? I mean, I'm not saying that we have a clear answer now, but I think we're working towards a clear answer in the really near future. So when we look at some of the biomarkers we use today in clinics, say CEA, a positive CEA is, especially under 10, is more often than not a false positive. Actually, 50% of the time, CEA comes at a false positive. I mean, remember, when we see our patients in clinic, let's say, your typical patient coming in after surgery, CEA is 5.3, and your upper limit of normal is 3. You get anxious, the patient gets anxious, you do 1 million scans, all the labs, even a PET scan, and you find nothing. And that's a common scenario. A lot of these patients come with these challenging challenging, findings. And this is where, MRD assessment may or may not be helpful. But the CEA certainly is a less sensitive and less specific test. And we'll see some of the data now in some of the prospective studies. So let's talk about the first point of entry with cell-free DNA excuse me, in the clinic. And that's, this was an observational study, stages 1 to 3 of colorectal cancer, published in JAMA Oncology. 125 patients included, mostly stage 3, some stage 2, and very few stage 1. This is a tissue agnostic platform, Signatera, meaning it's a tissue informed, but what you do is they take the tissue, they match it to the blood, and they follow up with blood. Having the tissue available, of course, in the early stage setting is not a challenge, unlike the later stage of the disease. And it does increase the level of sensitivity to match the tissue to the blood. What this study showed is that essentially, if a patient is MRD positive, not just initially, but at any point, the likelihood of recurrence is pretty high. It's close to 100%, essentially. If you have an MRD positive patient, the likelihood of recurrence is pretty high. On the other hand, if you had a negative MRD, which continues to be negative all the way through, that's the equivalent of a cure, at least, a prolonged disease-free survival and likely a cure. So we knew then that this is more likely to be a prognostic effect. There wasn't much to allow us to understand potential predictive value, and I'm not sure we have that yet, although we have a lot of signals that are pointing us in that direction that, MRD assessment will likely have some predictive role. In the near future, we'll see some more data with larger studies that do suggest that as well. Now, the lead time between an MRD positive disease and a CEA is essentially about 10 months, meaning you on average, you find your MRD positivity at around 6 months. For a CT, recurrence will show up at around 14 months, and if you rely on the CEA, it's about 19 months. Important to keep in mind. So we have that lead time from MRD to CT to CEA. The question is, in this about a year time between MRD positivity and a CT recurrence, what do we do? Right? I mean, that's an important question. And do we intensify the scans? Do we consider more treatment? And of course, these at this point of time, these questions remain unanswered. This study I like quite a bit. This is from our Japanese colleagues. Essentially, they did the study called Circulate Japan, which is a very large study, but mostly focusing now on the observational Galaxy arm. This is the one that was published in Nature Medicine recently. And this is the middle study, part of that whole Circulate Japan study, which essentially included 3 parts. MRD negative, MRD positive, going through the Vega and the Altair trial. Those are not presented or published yet. And then the Galaxy study, which essentially is a study that is observational in nature. This was the one that was published in Nature Medicine just this year. Included 1,500 patients, 1,000 patients were reported in the outcome cohort. About 852 were included in the MRD negative assessment cohort, and then in the MRD positive, and included the clearance analysis cohort, meaning those are patients, to see essentially if you convert positive to negative with adjuvant chemotherapy, and then the dynamics analysis cohort, and we'll talk about this as well. So overall, not unexpected, those patients who, after 18 months of follow-up, retained a negative status on MRD, ended up with an 18-month disease-free survival of 90%. So through follow-up, 90% of those patients did not recur at 18 months. On the other hand, those with positive MRD assessment at the beginning ended up with a 38% disease-free survival at 18 months, meaning that 62% ended up with a relapse or death by 18 months if they're MRD positive. Now, when we look at the CA and relative to the MRD assessment, if you had a patient with a CA positive disease and then MRD was negative, the chances of relapse are actually 12% at 18 months. So the CA again lacks that sensitivity and in that sense and that specificity. If the CA was negative, yet the MRD was positive, there was 70% chance of relapse. So the CA can be negative and yet the MRD positive, and you will see a 70% chance of relapse. So that's mostly observational, of course, but it's important. Now, as a reminder, like with the other study, there was no randomization around the question of chemotherapy versus no chemotherapy. The randomization was primarily, there was no randomization. This was an observational study. So the decision to do adjuvant chemotherapy relied on essentially the primary physician assessment of need. So when looking at the high-risk stage 2 or stage 3 disease, with MRD negative, and I think that's very important, if the MRD negative remained consistent through 18 plus months, versus adjuvant chemotherapy versus observation did not seem to be different when looking at disease-free survival. And that's very important. That's, the crux of, if we can show this prospectively in a randomized fashion, that ultimately, in the presence of MRD negative disease, we can skip chemotherapy. That would be fantastic for our patients, right? This is an important question across stages. We're not there yet, but I think, the signal is definitely pointing in a direction where in MRD negative disease, one could question the value of adjuvant chemotherapy. I wouldn't withhold it today, just because I need more randomized prospective analysis, but certainly it can enter into the discussion. For MRD positive disease, with adjuvant chemotherapy, the disease-free survival is 6 to 7 folds better than observation. So for those patients with MRD positive disease today, let's say you decide on your stage 2 colon cancer to do an MRD assessment. Well, you know what? If you actually end up with MRD positive disease, you will be obligated to give chemotherapy based on the trends of the data. One can argue back and forth whether you should do it or you should do it just on a very selective basis, which I don't routinely do in the low risk stage 2 patients, any MRD assessment, unless there are questions about chemotherapy or a desire for the patient to know the status of their MRD. Now, how about those patients who actually start negative, stay negative, start negative, go positive, start positive, go negative, and then those that persistently positive. Now, those that are positive and stay positive all the way through, they have really bad disease, unfortunately. For those actually who go from negative and go to positive, they don't do as bad, but they do relatively, the trends follow relatively those that are persistently positive. Those that are persistently negative do the best, and those that actually start positive and then go negative do close enough, to the persistently negative. So it's good to see that switch from positive to negative. It seems to actually improve the odds for the patient. We don't know whether the switch is related to chemotherapy, and we've seen, some differences in the previous slide. It could be that, we're clearing some of this, and that actually came in the next analysis, the clearance analysis from the study, which essentially did show that with adjuvant chemotherapy, there is ctDNA clearance in those patients versus those who just went on observation. And so very interesting, outcomes. And when you look at the 1-year disease-free survival, there were only 20% of patients who were disease-free and alive if they had no clearance versus 86% if there was evidence of clearance of their circulating tumor DNA with adjuvant chemotherapy. So pretty striking data. And again, all these are starting to tell us a little story there about MRD assessment and its value, its predictive value, pending more data coming from randomized clinical trial. One of those trials that was published in the New England Journal of Medicine, this was presented 2022 in ASCO, was essentially a study with stage 2 colon cancer. Both low risk and high risk were included in the study. Patients were randomized 2-to-1 for ctDNA guided management versus standard management. Now, if the patients went on standard management, the investigator will decide whether they get treatment or not based on conventional clinical pathologic criteria. On the other hand, for those who actually go through the ctDNA guided management, if they're positive, they will receive adjuvant chemo, and you decide whether it's oxaliplatin based or fluoropyrimidine. If they're negative, then they go on observation. Okay, the primary endpoint was relapse-free survival rate at 2 years, and that essentially was a non-inferiority endpoint. And then there was a key secondary endpoint of proportion of patients receiving adjuvant chemotherapy. Well, first thing first, this study met its primary endpoint of non-inferiority, meaning that going through a ctDNA guided management did not fare any worse than standard management, pretty much about the same. We're looking at the key secondary endpoint of adjuvant therapy received. Patients essentially who were on the ctDNA guided, meaning you use the MRD assessment as part of the guidance, half of them, half of the percent of the total percent for the standard management was in this group. So 15% of the patients on the ctDNA guided arm received adjuvant chemotherapy versus close to 30% on the standard management. But that comes with a caveat that if you have MRD positive disease, it was more likely to see the oncologist using an oxaliplatin based doublet versus what they routinely would use a fluoropyrimidine. That is certainly an important aspect also, that not we're using less chemo, but unfortunately, we're using more intense chemo. Whether that actually adds value or not is unknown. At least we know that overall, using less chemo, using chemo in less patients ended up not harming patients versus just standard management, and that's an important key point here. Now, how about the plasma-only circulating tumor DNA? These are tumor-specific, tissue uninformed. So they're tumor-specific because you're going to pick up, your 16 favorite methylated circulating free DNA and non-methylated circulating free DNA that correlate with the disease itself, and those essentially, are looked at in blood, and the patients are followed up with these liquid biopsies. Only, no tissue needed. You lose sensitivity here, and you don't lose specificity as much as you lose sensitivity and predictive value. I'll show you some of those results. When assessing circulating tumor DNA, you can see the specificity is at 100%, meaning, if it's positive, it's cancer. Sensitivity is 56%. You lose quite a bit on that. I mean, for the tissue-informed platforms, I mean, this is about 80%. When you look at the positive predictive value, it's 100%. Meaning, if MRD is positive, that means the cancer is going to progress at some point. The negative predictive value is a little bit more concerning, to be frank with you. The negative predictive value essentially tells us that 25% of the patients where you think there is no minimal residual disease present, there's actually minimal residual disease. Now, that does have implications when we think about withholding treatment or considering withholding treatment, or even considering a discussion about withholding treatment using this platform. When you look at the CA, you can see that the positive and the negative predictive values are pretty dismal for CA, which continues to be a consistent theme that CA is not really your best platform. So where we're going next is, we have 3 studies and more in the US, but 3 major studies, NRG, looking at essentially randomizing patients to testing the presence of circulating free DNA versus standard of care. And so similar to Dynamic, that study is accruing. Circulate US, which is trying to address the questions of MRD negative, MRD positive, similar to Circulate Japan, but also there's another aspect of the study essentially that is trying to look at what happens to those MRD negative patients who don't get adjuvant chemo, and then they turn positive. Those patients essentially, before even we see results, before we see any evidence of lesions on scan, they get randomized to chemotherapy or more intense chemotherapy. And then another study, Stand Up to Cancer, smaller study, but this is looking essentially at, rather than switching chemotherapy, moving to a more biologic or immune therapy agent. So changing how we target the cancer, hoping that essentially you move from, lack of response to chemotherapy to perhaps hitting biology early and changing the outcome of patients. So we have the potential to transform clinical practice with MRD assessment. We get 2 platforms, tumor-informed, tumor-naive. I prefer the tumor-informed, especially for the earlier stages, and we have ample tissue that does increase the sensitivity and the predictive value. This lead time diagnosis remains problematic, and we need to study it a little bit further. I mean, what do I do from the time MRD is positive after adjuvant chemotherapy to the point where I see the tumor on a scan? A lot of anxiety, a lot of unknowns. This is being studied now, so we'll understand a little bit more. And then, of course, does that affect duration of adjuvant chemotherapy, whether we give it or not? So some of these elements that I just showed you are pointing out in the direction that would help us predict who benefits and perhaps even cut down on the duration. Intensity of radiologic surveillance, perhaps, as another outcome. But overall, I think we'd like to see all these randomized clinical trials being completed to help us answer some of these pending questions. All right, so I will move on to the case, and then at the end we'll take some questions, and that's Dr. Brenner first.
Yeah, that's me.
Okay, please, Warren, how are you?
Hi, good. How are you?
Good, thank you.
Yeah, this was an interesting lady. She had a right-sided colon cancer that was MSI high and BRAF mutated. She had quite a severe underlying neurological disorder, so we couldn't use oxaliplatin. She had a good functional status otherwise, and she was enrolled on the bespoke clinical trial, which was using the Signatera platform in patients with stage 2 to 3 colon cancer. So she was negative at diagnosis, and then in the midst of a 5FU-based adjuvant therapy, a Signatera became positive, despite a completely normal CA. And then I imaged her. I don't typically image during adjuvant therapy otherwise, and she had no new symptoms and was found to have a mesenteric mass consistent with recurrence. And given the MSI high status, we treated her with single agent pembrolizumab, and on that had a rising quantitative level of the Signatera again, with growth of the mesenteric mass. And again, CA remained normal throughout this. And we then switched it to encorafenib cetuximab with Signatera decline, consistent with the response. And now her Signatera is actually negative, ongoing for greater than 5 months on the encorafenib and cetuximab. So I think it was a good example of using Signatera, because otherwise we wouldn't have known about this. She would have completed 6 months of therapy that wasn't helpful. And it's been a very useful way of monitoring her given a normal CA level, and nothing physically that we can feel from an exam perspective.
That's a superb case. Thank you for sharing it. Can I ask a quick question? When the patient went on pembrolizumab and there was growth of the mesenteric mass, although I mean, we don't frankly see pseudoprogression as much in these patients. Was there a possibility that she actually would still have responded to pembrolizumab if you continued, or this was quite a bit of growth?
It was quite a bit of growth, but I think that's actually where the Signatera was helpful as well. And I don't know if there's any data on what happens with a test like Signatera if there's pseudoprogression.
Yeah, there is no data. And I think the rising Signatera is definitely, when they had that immunosurveillance study that was published, I think in Nature, there's certainly, elements there that are very consistent with what your observation is here, is that with a rising, circulating tumor DNA, comes essentially, you can assess progression earlier than the scan. So I think, your thoughts are certainly consistent with the published literature.
Yeah, and that's exactly what my thought was, that
Yeah.
I always questioned whether this was potentially pseudoprogression. And again, using the rationale that the Signatera was clearly rising. I mean, I should have sent you a graph of what it looked like, but it was on a significant upslope. So that's why I thought it was probably consistent with true progression rather than pseudoprogression, and change in therapy, normal became negative, which was reassuring that we made the right decision.
Great. And there's a study called CMARC right now that's looking at pembro encositux versus pembro followed by encositux in this particular patient population, because the MSI-H subgroup with BRAFV600 is less likely to respond well to IO. So that's a fantastic case. Thank you. And it's a rare patient population. Great case. Thank you.
This is just an example of where I've been using it in patients with stage 4 disease.
Okay.
This was a 51-year-old male with a metastatic sigmoid colon cancer. From my recollection, I think he was KRAS mutated,
Okay.
and he got treated with neoadjuvant FOLFIRINOX plus BEV. I guess we can argue about whether BEV was needed or not.
Sure.
And then he underwent a right-sided hepatectomy, and then he also had his sigmoid colon resected in one procedure. And then he completed 6 cycles of 5-FU-based therapy. We could not give him additional oxaliplatin. He probably had a grade 2 neuropathy. And now I've been using Signatera in him, and he's CA throughout his disease course. Also, when he was diagnosed with fairly large tumor burden in the liver, CA level was normal. And now I'm monitoring him with, again, Signatera platform, and he remains negative.
Are you doing Signatera in conjunction with the scans alternating or something like that? How you doing?
Yeah, so I mean, part of the reason I'm also using it is, probably scanning people less, just because, it's so sensitive.
Mm-hmm.
So I still scan probably every 6 to 12 months, given it, I guess there could be a small false negative rate. But I'm definitely scanning less when I'm using Signatera.
Did you just another question to you? Did you start doing the CT, the MRD assessment after treatment, during treatment, or before you started treatment?
I only did it after he
Got it.
had his surgical procedures and was rendered disease-free.
And it was negative then?
Yes.
Okay. All right. Ideally, and I've been doing this more and more with the oligometastatic disease. I think it's a great setting for it. We still need to learn a little bit more about how to best use it. But to avoid any potential negative predictive value, probably sooner if that was the plan than later, just to make sure that that's indeed for the 10-15% of patients that's indeed MRD positive to negative. But this is again another good example of usage of this in oligometastatic disease. Again, thank you for sharing.
May I ask a question?
Yes, please.
Do you have any pushback from the insurance company for like stage 4 ordering circulating tumor DNA, for checking progress and disease?
In the oligometastatic disease, I haven't had any issues. I don't know, Warren, have you had any issues with those patients?
Signatera, I haven't. I have used Guardant as well, and I've had a few issues. But Signatera doesn't even do balance billing. They don't come after the patients at all. Guardant's a little different, but I prefer the tissue-informed circulating tumor DNA, and also I like the fact that it's quantitative. The Guardant's just either positive or negative. So I like the quantitative, way of following it.
Yeah, I haven't had any issues. Okay, Evan, I think that's your case.
Yeah. So this is the lady, 54 years old, and she was diagnosed with colon cancer in early 2022. She had a right-sided colon cancer, and it was stage 3B, 4 lymph nodes involved, and high-risk disease. So she obviously was treated with adjuvant chemotherapy, FOLFOX, which was finished last August. And sorry for the typo here. But anyway, so I was just monitoring, and I saw her just at the end of last year. I did a CT scan that showed, that showed a mass about 2.1 centimeter in the right lobe. And so I did biopsy. We did a biopsy that confirmed metastatic disease. And then I also did a PET scan. The PET scan showed 2 lesions in the right hepatic lobe, one about 2, the other about 3 centimeter, with SUV of about 15 or 16. So I did send the patient to have a consultation, surgical consultation, and see whether it can be resected. But then obviously we have to. I did the NGS, and you can see that the lady has RAS mutation and HER2 negative, and what else? Yeah, I think that's it. So I kind of decided to go ahead and treat with FOLFIRI plus bevacizumab, and then give a few cycles, see how she responds, and then the question about circulating TNA, maybe to monitor the disease. Of course, we have we'll follow with CT scan and to see how she responds radiographically.
So is she resectable? Is she potentially resectable?
Right. I think she potentially resectable. There are 2 lesions in the right hepatic lobe.
Okay. So your hope is that you can bring her to resection and then follow her up with circulating tumor DNA and scans.
Right. So I'm concerned that whether this lady even will respond to FOLFIRI plus bevacizumab, and the CT scan of course can tell me.
So does she have neuropathy?
She does have neuropathy.
Okay, so you can't really go back to oxaliplatin. Her chances of responding to, and she doesn't have to have a G12C by any chance.
Yeah, she has G12V. V as Victor.
V. Okay, so the second most common.
Right.
I think you don't have much of an option other than FOLFIRI, but bevacizumab. Hope that she does get a response, and her chances of a response are about 20-30%. Although with liver only, maybe a little bit higher. So you could certainly see a response, and if you see the response and you can address the disease local regionally, those patients would do well. The RAS mutation is concerning certainly, and the fact that her recurrence happened, after 12 months from her surgery, puts her in a little bit more of a biologically favorable group. So this is late metachronous rather than early metachronous. So that, she's 1 month off, right at the border between early and late metachronous. And so that may essentially give the patient a better prognosis overall. So hopefully she will respond.
Mhm. Great, thank you.
Yeah, but that's what I would do. There's nothing else that can be done at this point.
Great, thank you.
Yeah, you're welcome. Thank you.